afternoon, everyone. Welcome to the final session of the ACPMP Research Foundation's Symposium. I'm just going to say a few words about Dr. Laura Lambert. We're just saying that I've known her about over a little bit more than 10 years. She has been an amazing advocate for the Research Foundation. She came to the Philadelphia area for our first symposium. Then myself and another board member went out to UMass for the symposium that she held. She even came to our walk. We just pushed everybody into helping us out with the foundation. But not only is she an amazing surgeon, she is such an advocate for all of her patients. She just is amazing how she really cares about them, and not just during the surgery, but afterwards, and we're lucky to have her on our team. So I'm going to hand it over to Dr. Lambert, and she will continue with the Q&A.
Great. Thank you very much, Judy, for that lovely introduction. And as I've said before, it's just been a privilege and an honor of my career to work with the ACPMP group and really support your efforts, in an area where people just feel so alone when they get that diagnosis and really don't know where to turn. I always tell people there's only a couple of websites that I trust, and yours is one of them. So I hand that out in clinic regularly. So welcome everybody to our regional part of the symposium put on by the Huntsman Cancer Institute and the University of Utah. It's a pleasure to be here today. And I am really excited. So for some background, I joined the program here at the Huntsman Cancer Institute 5 years ago now. It'll be 5 years in January. And the program has just really grown. I think it's been a tremendous benefit to the people of the Intermountain West to have this resource available to them. Prior to my coming here and starting the program, people from this region were traveling all around the country to get the care that they needed from a high volume center and have the surgery that they needed. So it has been one of the highlights of my career to bring this to this area. And the program has been so successful that I am delighted to introduce Dr. Erin Ward, who is a surgical oncologist, and she's going to be joining me and us here at the Huntsman on November 1st next week. And part of her practice is going to be dedicated towards the management of peritoneal carcinomatosis and doing HIPEC. And I'm just thrilled to be having her come on as a partner, and look forward to working together. And I know that she's going to bring a whole nother skill set and area of expertise that's only going to help us take the program to the next level and to provide even more comprehensive and better care for our patients and their families. And I just thrilled about this opportunity. And I've invited her to talk today so that she can introduce herself to us and also share her passion for patient-centered outcomes. And where, as part of her role here, she's going to be doing research and to share her vision for that and what we can look forward to in the future. So without further ado, Dr. Ward, please.
Thank you so much for that kind introduction. I'm very excited to get started at the Huntsman Cancer Institute. And a special thank you to the ACPMP Multi-Regional Symposium. This is a wonderful opportunity, and I'm very grateful for the opportunity to talk a little bit more about what I am really passionate about. And that is really about addressing the impact or influence of psychosocial health on cancer patients' outcomes. So I have no disclosures. Just a brief outline. First, I'll start by defining psychosocial health, what that means to the literature, patients, and what it means to me when I'm going to talk about it more. A little bit more about why it's important and how it impacts cancer patients, and then delve into a couple studies that really look at the impact of psychosocial health on patients undergoing cytoreductive surgery and HIPEC, and how it may impact their outcomes. And then talk a little bit about what's available at the Huntsman Cancer Center right now to address some of these psychosocial health issues, and then kind of future paths and projects that I'd like to get going when I get started. So psychosocial health is really a broad overarching term that tries to encompass all of the different aspects that go into somebody's overarching health. So both cognitive, behavioral, emotional, social, spiritual, in addition to physical health. We've talked a lot during the symposium about, different ways to help cancer or patients with appendiceal cancer get better care, and pushing forward beyond just HIPEC. And one of the ways I think we need to do that is by addressing not just somebody's physical health, but really considering their whole psychosocial health as well. So I think all of us know that when you get a diagnosis of cancer, it affects more than just your physical health. And the NCCN has recognized that this is a critical aspect of cancer patients' health, and have actually dedicated a specific guideline to address what they term psychosocial distress for cancer patients. And to them, this means essentially any distress on any of those factors that I just talked about that may impede a patient's ability to get through cancer treatment or recover from cancer treatment. One of the ways that psychosocial distress can come to fruition for patients, and that's easy to measure, is depression and anxiety. And what we know from the literature is that patients with cancer are more affected with depression and anxiety than the general population, with up to 20% of patients having depression and 10% having anxiety, respectively. And what's interesting about psychosocial health in cancer is that it has a bidirectional relationship. Cancer treatment can obviously impact patients' ability, psychosocial health, can make it tougher to tolerate the ups and downs of life, can lead to depressive anxiety symptoms or other issues like financial or social isolation. But psychosocial health can actually impact a patient's ability to finish cancer treatment or recover. So there's this bidirectional relationship that I think is really important for us to further understand going forward. And there is a lot of research out there. It's kind of all over. But what we do know is that depression rates overall are higher in cancer patients, but they also vary by the type of cancer. And they tend to be higher in patients with gastrointestinal cancer, such as appendiceal cancer, with up to 31% of patients reporting depressive symptoms. And these rates of depression can vary during treatment. So they tend to be highest during treatment, whether it's during chemotherapy or at the time of surgery, and they do tend to improve over time. We also know that these patients with depression and anxiety symptoms, which again is just a marker of psychosocial health that is overall easier to measure and often cited in the literature, that these patients with these symptoms have actually worse cancer-specific outcomes compared to those who do not. So they actually have almost disparities in their outcomes. And these depression anxiety symptoms are associated with worse pain control, higher readmissions, and longer recovery time. So all things that are important to both patients as well as clinicians. And when we look at research that actually looks at psychosocial health specifically in patients treated with cytoreductive surgery and HIPEC, we find similar findings that patients with clinically significant depression symptoms prior to undergoing cytoreductive surgery and HIPEC have higher rates of 30-day mortality and readmissions. And what's most interesting is that this stays true even when controlling for things like disease type or burden. So this is an area that really needs to be better addressed. The next study, this group wanted to better understand the unique experience of patients undergoing cytoreductive surgery and HIPEC. And what they did is interviews with 20 patients at separate time points after patients had the surgery, and try to figure out themes that were important or consistent among patients. And what they found was 3 months after surgery, Many patients reported depressive symptoms, and this was surprising not only to the patients but also the investigators. They expected to find things like fatigue or sleep deprivation, but overall the patients often reported symptoms of depression, even in the setting of no personal history of depression. And the patients often reported around this 3-month period about significant concerns about the burdens being put on their caregivers, and described almost a sense of loss of team or almost abandonment after discharge from the hospital. They went from this sense of a full team of people really helping them after such a big surgery to feeling like they were a little bit out on their own at home. Despite this, 90% of patients did report that the relationships with their partners and friends were stronger or unchanged 6 to 12 months after surgery, so they did survive the whole experience. But many of the patients reported a continued preoccupation with concerns of death and cancer recurrence, which had an impact and was very disturbing for many of the patients. So there are many programs out there to help address some of the psychosocial health aspects of cancer care. And I just wanted to highlight just a few of the programs that currently exist at the Huntsman Cancer Center to try to address some of these issues, particularly for our patients who undergo cytoreductive surgery and HIPEC. So one of them is the Wellness and Integrative Health Center. So this is essentially a center developed to provide classes and services aimed to foster lifelong well-being for people affected by cancer. So it's a conglomeration of different classes and services, including acupuncture, rehab to try to get patients back to feeling strong, creative arts, massage therapy, and musical therapy. And what's unique about this service is that some of these are also offered not only in the outpatient but in the inpatient, and many are offered for our caregivers of our patients. And one of the other amazing opportunities our patients have that we integrate as part of the care for our patients with cytoreductive surgery is the Huntsman at Home program, which provides essentially continued care under the direction of your physician at home. So after you get discharged from the hospital, nurse practitioners will come to the house and help you manage and treat symptoms, update your physician, and also help give that coaching to your family and caregivers to help ease that transition from going from the hospital to home. In addition, they provide palliative care and hospice options for those patients. And finally, one of the other programs that exists at the Huntsman Cancer Institute is the supportive oncology and survivorship. So this is aimed to just provide additional support during and after treatment, and really focuses on treating some of these pain and symptom management, whether it's through one-on-one or group support. There are there's actually like a men's cancer group and other cancer groups designed to provide specific types of support for different patients undergoing cancer treatment. So in terms of future paths and plans, so I really believe that what is important to guide and design new interventions to address some of these psychosocial health issues is allowing the patient experience to guide the interventions we do choose to pursue and assess those interventions. And one way to do that is really integrating patient-reported outcomes measures into our clinics and part of our patient care. So patient-reported outcomes are essentially validated survey measures that allow clinicians and researchers to reliably evaluate symptoms that are important to clinicians and patients and quality of life measures. One such measure is called the PROMISE measure, which is an NIH program where they validated all of these person-centered measures for physical, mental, and social health in both children and adults. It allows you to compare different attributes among both patients from time to time, as well as to the general population. So I'm just going to use this next study that I did at my last institution to kind of make an example of how you can use patient-reported outcomes to really take what you are assuming is important to the patient or is happening during treatment and maybe change what interventions you design. So this was actually a study done in pancreatic cancer patients. So the previous older studies have really said that all these patients, or a large percentage of them, will have depressive symptoms. So we really wanted to understand if this was true and how multimodal therapy, chemo, surgery, and radiation all impacted patients' psychosocial health during the treatment and after. So we had all of the patients with pancreatic cancer who were treated at our institution fill out these promise questionnaires that you can be on paper or on your smartphone. They're 4 to 6 questions about depression, anxiety, social engagement, and sense of purpose of meaning, purpose and meaning in life. And they did it at predetermined time points during their treatment. And instead of finding that what we thought we were going to find, which was, significant symptoms of depression, we actually found that compared to the general population, the patients didn't have any significant symptoms of depression, at least that were quantified with this measure. But we did find that most patients had significant anxiety right at the time of diagnosis, when there was a lot of unknowns, and right prior to surgery, where there was a lot of unknowns. And right after surgery, when there was a lot of physical healing, etc., that's when they really struggled with the social engagement. I would imagine some of those things like feeling, when they get discharged and feeling like there's a lot of burdens on family also played into that. And what was interesting and very inspiring was that all of these patients at all time points during all of the treatment reported significant greater sense of purpose and meaning to life compared to the general population. So, let's see. Oh, here we go. So moving forward, the growth plan is to start to integrate patient-reported outcomes as part of our regular care. I think what's most important about that is it helps you make sure you don't miss the opportunity to design interventions that are important to patients. Make sure it gives you a way to measure if these interventions are actually affecting what's important to the patient's psychosocial health. So those are kind of the next steps, and I'm really excited to get started, and I just want to say thank you again to Dr. Lambert and the Appendix Cancer Pseudomyxoma Parent Research Foundation for the opportunity to talk.
Great. Well, thank you, Dr. Ward, and I'm really excited about getting going and adding this whole aspect of psychosocial, the impact of psychosocial health on our outcomes, and seeing what we can do to improve our patients' experience and outcomes through this avenue, and doing some research with you in this going forward. We will open up the panel to any questions that anybody might have from the audience, either for Dr. Ward or anything related to the general session. She and I will do the best we can. Maybe some questions about investigational drugs I might not be able to answer, but if there's any questions certainly pertaining to surgery or general management of appendiceal cancer, please, we'll be happy to answer those. And maybe while we're waiting to see if there are any questions that come up, I'll look through some of the pre-submitted questions and see which ones that we haven't gotten to yet. One question that I get a lot is, and Dr. Chiraga talked on this a little bit, is diet. Is there a particular diet? Are cancer cells particularly, do they have preferences in terms of where they get their nutrition and what drives them to grow? And I think the short answer is, I wish there was a diet that we could just offer to everybody that would really help fight cancer cells. I think a lot of people focus on sugar. We know that cancer cells do prefer sugar as their source of energy, and so a lot of people hope that if they can just decrease the amount of sugar in their diet, that they can kind of starve the cancer cells. Unfortunately, both our brain and our heart both need sugar, to survive and to function optimally, and our body has a system for regulating blood sugar, and if we're not giving it sugar, it will get sugar from other sources like breakdown protein and fat, and that obviously has an impact on a person's health. So avoiding all sugars might be tough. I don't know of any particular nutritional supplements that fight the growth of, this question was laminin in particular, would it help the immune system? I kind of agree with Dr. Taraga, just a healthy diet, all things in moderation, lots of good fruits and vegetables, I think that can't hurt. Dr. Ward, do you have any other thoughts or comments on diet and supplements?
No, I mean, I think I just echo what you said, and just, I think it's easy to want to control something, and I think that's the first thing that comes to mind, but ultimately I think, a healthy, broad diet is probably the best thing we have to offer. I don't know of any supplements or anything particular.
Right, and I really do wish there was a diet, if we could just tell everybody go on this and it will definitely prevent the cancer from coming back or slow down its growth. I would have that. I'd be on it and I'd have everybody else on it.
Yeah.
Judy, do you have a question?
Yes. As a previous caregiver, and I wanted to touch on what Dr. Ward had said about patients feeling alone after they left the hospital. And so does Huntsman have anything set up for the patients that have traveled to Huntsman? Because like through your presentation, it was like a PA can reach out to you, but whether it's Huntsman or different facilities that would do the cytoreductive HIPEC, a lot of travel. Like my husband and myself, we travel close to 2 hours. And yes, once you leave after the surgery, you're kind of on your own. Like you'll make a phone call if you have a question, but your primary doesn't really know much about the surgery you had. So that is definitely an area that I feel like all these years later, that's still a struggle for the patients and their caregivers. So I don't know if Huntsman had something in place, sometimes the resources when you can't go back to Huntsman.
I think, and Dr. Lambert, you'll have to fill it in, but I do know that one of the ways that, at both the previous institutions and what I understand to be true about Huntsman is there are resources to try to stay locally for a little, some period of time initially after surgery, where there's either, I think with the Huntsman, it's severely discounted hotels or other places nearby, where I think sometimes staying a week or so after initially the bigger surgery is helpful to try to make that transition. I think the other thing that was almost the silver lining of COVID was, virtual or video visits are a little bit easier, and making it a little bit easier to sneak you into clinic, even if you're not in person, to answer some of those questions, I think kind of eased some of that, but I don't know if there's any other specific resources that exist.
Right, yeah, so for the Huntsman at home that Dr. Ward was talking about, it is unfortunately geographically restricted. I mean, obviously it has to be within the state, but also within, it started off in a 30-mile radius around the Huntsman, so you had to live even that close for that to happen. And so, and obviously it would be a challenge to treat somebody outside of the state if you don't have a license to practice in that state. And we have people coming from all over the Intermountain West, so traveling for hours and sometimes even flying in. And so, like Dr. Ward said, we often recommend that people stick around the area for about a week after the surgery if they're going to be traveling far away, see them in clinic before they head out, and then the virtual thing, I think it's fantastic because I've literally seen patients who are in a wound clinic dealing with a wound problem with the wound care nurse there and me looking at it and helping troubleshoot, what's going on and how does it work. And so I hope that helps them feel like, they're not as much out there on their own, with somebody trying to take a guess. And as you probably know, Judy and probably other people on the call here, when you pitch up in an emergency room somewhere and you've had cytoreductive surgery in HIPEC, they take one look at your record and they're like, we are not touching this, right? Like, we have no idea what happened and what this means. So it is challenging, and I'm sure it's very isolating to have that. So, I can speak for myself, but I can also speak generally for the HIPEC community. I know Dr. Greenbaum's on the call too, as well as that, and Dr. Sood, who's also starting and doing HIPEC as well. In general, the community is very receptive to getting phone calls from other people in the community. If somebody does show up in their clinic or their emergency room, we're always available, and we really, as a community of surgeons, really care about the people that we've operated on and want them to do well, and we own these surgeries and the outcomes of them, and we want to be able to help in any way that we can to address questions that come up. And we recognize that this is out of the wheelhouse of most practitioners, and it can be daunting. So hopefully that helps. I would, I give my cell phone out to a lot of patients, so it's not all of them. And so I'm frequently getting a phone call from an emergency room somewhere, this is Dr. So-and-so, can I talk to you about your patient? So hopefully most people can avail themselves of something like that. So there's a couple of questions in the chat. One, somebody's having a 3-year checkup with the local oncologist, and he suggested having the DNA from the tumor tested. So I'm not really, it seems like the question sort of just ended, but I'm guessing that this is the DNA from the tumor from the original surgery, and that's not unreasonable to do. If that was not tested originally, we're looking for options for what people have talked about before for targeted therapies towards the actual mutations that are present in the tumor, actionable targets, and hopefully you haven't had a recurrence yet, and this is just to check and make sure that if you do need treatment at some point, if the cancer came back, that they would just be aware of all the options for you. So that's I'm just kind of guessing because it was sort of a limited question there. And then the next question is, do we have any formal or organized programs for pre-surgery counseling and prehab? Yes, we do. It's exactly for prehab, and there's definitely, I'm sure Dr. Ward's aware of this data, there's definitely data to show that people who have prehab do better in terms of their recovery from surgery. Dr. Ward, you want to talk about prehab?
Yeah, I think, there's the traditional prehab is always kind of focused on nutrition and physical. I think my hope is to integrate, the psychosocial aspect, which at my last institution was part of kind of the checklist of before undergoing large surgeries, was to meet with a psycho-oncologist to kind of provide the additional support that's needed to get through something like a big surgery. But yeah, the research shows that, giving patients the right tools and helping them get ready for, in my mind, is kind of like a marathon, like training, helps them recover quicker and helps them bounce back. And if they need additional treatments, helps them actually make it to those additional treatments.
Yeah. That's exactly what I tell people. People always ask, what can I do to help prepare for cytoreduction in HIPEC? And my first question is, do you smoke? And if they say no, I ask them not to start. Usually a chuckle. And then we talk about, not smoking. Protein, right? So protein is the glue that holds us together. And, when you're having a big surgery like this, you need a lot of protein to heal well. And actually, if your protein levels are too low, it may prevent us from doing certain parts of the surgery that we would otherwise do. And then exercise, and I say aerobic exercise. So whatever you can do, walking, running, hiking, whatever, swimming, whatever it is, aerobic exercise, I think, is the most helpful. Just like you said, think about like you're preparing for a marathon.
Yeah.
And people who have better aerobic stamina do better after big surgery. It's not that people who aren't athletic can't get through the surgery, but it definitely helps. The more fit you are coming into a big operation, the easier your recovery will be afterwards to get back to that level. So, great. Let's see. So another question. Many people have small bowel obstructions after cytodectin HIPEC. The question is it because of the surgery, the recurrence, and does the susceptibility increase over time, perhaps due to adhesion growth? Oh boy, isn't this like the holy grail? Like if we could solve the problem of adhesions, that would be terrific. I think the answer to the question after cytodectin HIPEC, it could be either one, right? It can be either adhesions or it can be a tumor recurrence that can cause that. In my experience, usually the susceptibility does not necessarily increase over time, but if somebody has a small bowel obstruction that's managed, it's hard to, it's absolutely 100% hard to predict who's going to get a small bowel obstruction. If you get one, are you more at risk to get another one? Probably. How high is that risk? Not sure. It depends. It also depends on the timing after the surgery. So if it happens really early after the surgery, it's more likely going to need surgery to fix it than if it happens much later. Oftentimes we can manage those without surgery, and then it really depends on the clinical situation, whether the person's having pain, if their bowel is threatened, and what it's due to, how it's managed. Thoughts on that, Dr. Ward, on small bowel obstructions?
No, they seem to be the gift that keeps on giving.
Unfortunately.
It does seem like some people are more prone to them, and again, if we had the magic answer of why, we would avoid doing whatever we needed to or warn people. But sometimes imaging can give you some insight into what it is, and sometimes you just have to go along with it and manage it as they come up.
Yeah, exactly. We have another question. Do we have data for looking at KRAS inhibitors before cytoreduction and HIPEC? We know that we need 6 weeks apart for Avastin, for example. Right, so we do like people to hold their Avastin for at least 4 to 6 weeks prior to surgery. And the reason for that is Avastin attacks actually the abnormal blood vessels that tumors actually cultivate so that they can get a blood supply. And we know that Avastin, which is a monoclonal antibody, can inhibit wound healing. And so it puts people at risk for complications for wound healing before and after surgery. So that's why the medical oncologists and the surgeons want them to hold that. For the KRAS inhibitors that are the tyrosine kinase inhibitors, I'm not aware that there's an impact on wound healing for those as much as the Avastin. I've not had anybody with appendix cancer being treated with those, so I haven't had the issue of whether or not to hold them. Do you know, Dr. Ward, are you familiar with any issues with the tyrosine kinase inhibitors?
No, I haven't had any personal experience, nor can I think of any literature that really supports one way or the other.
Yeah, I think those are less impactful, less concerning with regards to wound healing. That's really kind of a unique feature of bevacizumab or Avastin. Yeah. A question about chemotherapy. Do all appendix cancers need chemotherapy? And the answer to that is no, if this is specifically referring to systemic chemotherapy. The answer to that is no. As was talked about earlier in the general session, the low-grade mucinous neoplasms really don't, kind of getting back to Dr. Mastraggi's talk about whether or not it's actually cancer, right, first of all, and then these very slow-growing, indolent almost normal-looking low-grade mucinous neoplasms that are encased in mucin and in the peritoneal cavity, they just really don't tend to respond to systemic chemotherapy at all. And so most medical oncologists are not offering that for them, and with good reason. We don't want to give people chemotherapy that's not going to be helpful. And appendix cancers that are identified early and confined to the appendix and haven't spread to lymph nodes that are removed with surgery and all the margins are negative, those don't necessarily need chemotherapy either. So if they're really caught at an early stage, if they have indeed a true cancer and it has perforated the appendix but not spread to the lymph nodes, that's what we call a high-risk stage 2 cancer, and often the medical oncologist will discuss with the person about doing systemic chemotherapy. Similarly, if the cancer cells have spread to the regional lymph nodes, then that would be a stage 3 cancer, and chemotherapy would be recommended for that as well. So it is very, the answer to that question about when to do systemic chemotherapy is really dependent on the histology, or how the cancer looks under the microscope, and the stage at which it's presenting and the circumstances in which it's presenting. So, great. A couple more questions in the Q&A. Is a moderately differentiated adenocarcinoma considered high grade? Dr. Ward, how do you approach moderately differentiated appendiceal cancers? Where do you classify them on the spectrum?
I think I'm with Taraga that, it's easier for me, and I think seems to pan out that, low grade is different than the high grade and moderate. So I think I say that with a grain of salt. High grade is, when they describe it as high grade versus moderate grade, it still means that they're different, right? So the pathologist sees something different. So it may not have as the same outcomes as what is traditionally described as high grade, but since the treatment is so different from high grade, moderate, than low grade, I tend to group them together.
Yeah, I do too. I usually when I meet somebody who's just gotten the diagnosis, I tell people that these are rare tumors, as we all know, and yet interestingly, there's a spectrum of them, right, from those low-grade mucinous neoplasms that technically aren't a cancer but have their own set of issues. And then when the cancers cross that line, and basically that line was what Dr. Mastraggi was showing in those beautiful slides today, about when those glands get outside of the mucosa and starting to invade the muscular layer of the appendix, then now you have a true cancer. So now it's an adenocarcinoma, and then the pathologists divide that up into 3 different groups. So low grade appendiceal adenocarcinoma, moderately differentiated in the middle, and then at the higher end, the high grade or poorly differentiated or signet ring cell. And I usually split them, just like you said, between the low grade adenocarcinoma, and often treat those very similar to a lamin, and then moderately differentiated to higher end. And that's really important because it also determines whether the person should have part of their colon removed, right? So the appendix hangs off of the right colon, and once you get into that, once the tumor has gotten to that moderately differentiated histology, the risk of cancer cells spreading to the lymph nodes in that area goes up significantly. So for low-grade adenocarcinomas, we know that the risk of lymph node spread is less than 5%, or about 5 to 7%. It goes up to 25 to 40% for moderately differentiated, and higher than that. So in addition to thinking about systemic chemotherapy, we also recommend removing the right colon if it hasn't been done, to test those lymph nodes in that area to better stage the person and get the prognosis going forward. So I'm with you. While I do think they have a better outcome than signet ring cell or high grade, really poorly differentiated cancers, we in terms of the treatment algorithm, they go with that higher grade. So exactly. Any advice about getting back to regular exercise routine after CRS, HIPEC, or EPIC? Dr. Ward, what are you gonna be telling your patients?
I think that the first thing to remember is, you've been through a big trauma and your body's been through a big trauma, and part of that is giving yourself time to heal, and allowing your abdominal muscles to heal after a big incision. So I think first and foremost is not pushing it too early, and giving your abdominal muscles time to heal. And then, getting that okay from your surgeon, and then starting small and giving yourself credit for what you're doing, which is hard work. So, I think a walking program early, and then often 6 to 8 weeks, depending on what else is being integrated into your care, whether it's additional chemo or et cetera, is when to start asking about what other kind of exercises are appropriate.
Oh, great. Yeah. So one of our partners explains it to her patients this way. So if you break your pelvis, right, out skiing or something, it's 6 to 8 weeks of not bearing any weight on your pelvis, right? Mm-hmm. And she said, effectively, when we do a big surgery on your abdomen, we've broken your abdomen, and it takes about 6 to 8 weeks for that to heal and recover. That's not a bad analogy. Obviously, we don't want people just not weight bearing or laying in bed or anything like that. We want people getting up and walking around, and I think most HIPEC programs would have physical therapy and occupational therapy, working with people from day one after the surgery, getting people out of bed. The things that we worry about by being just being in bed are getting a blood clot. It's a high risk after any surgery, but even higher risk for surgery for cancer. So we take extra precautions to prevent that by giving blood thinners and getting people up and moving around as quickly as possible. Plus, it helps you just feel more human to get out of the bed and move around. It also helps prevent pneumonia, because we want you to be coughing and taking deep breaths, and getting up and walking around helps that. It also is probably the only thing that we can really do to help get your bowels going after the surgery, and that's what honestly keeps people in the hospital for as long as they need to stay in the hospital, or causes the most trouble after the surgery, is the bowels going to sleep because of the surgery and the heated chemotherapy. But we do want people to avoid any real heavy lifting for a good 6 weeks. I recommend 6 weeks after the surgery, because we don't want people to get a hernia. We want that area to heal, the incision to heal. Because if you get a hernia and you have to have that fixed, then it's like 12 weeks of not lifting anything. So gradually increasing your activity level, but just like Dr. Ward said, not pushing it, because you don't want to hurt yourself, and you want to really feel like you're making steady progress. And so one of the, a lot of times you'll see that the progress after surgery is, you make like 2 steps forward and you feel really great one day, and you do a little too much, and the next day you really feel like you've slid backwards and you're tired. And I recommend people not to look back to the day before, but to look like back a week earlier, right? And just see how far you've come, so you constantly see that you are indeed making progress and feeling better. And if you're not, or you're worried about something, reach out to your surgeon or their team, and find out, make sure that they feel like you're on the right track, because they've seen a lot of this, and they know what to expect, and they know what's normal, but you may not, just because you've never been through this, or your loved one may, you may not know what's normal to expect for the person that's going through it. Judy, you have another question? Oh, Judy, I think you're muted. There you go.
So I'm going back close to 18 years, and I have not heard this discussed at all today, so I don't even know if it's an option any longer. When my husband had the HIPEC, he also had the chemo 5 days after surgery, right into his abdominal area. Is that an option any longer, or is that just been decided it's really not necessary, or it doesn't make a difference?
Dr. Ward, do you know?
So was there a tube left in and then they did additional perfusion in his peritoneum?
Yes, most of all his tubes were left in, yep. And then during those 5 days, he also had to, go from one side to another during the day when they did that. So I'm just curious, I haven't heard that mentioned also. I thought maybe that is not part of treatments any longer.
This actually might predate Dr. Ward's experience.
I am going back to 2004.
Yeah, so we're talking about HIPEC, and actually Dr. Sugarbaker just published a paper looking at HIPEC, and he looked back at his experience and found that it really probably wasn't as helpful as I think he was hoping it would be. There is a study, we're going to be, again, stay tuned, we're going to be getting the results of the Icarus trial from Memorial Sloan Kettering, which randomized people to get HIPEC versus HIPEC and not HIPEC plus HIPEC. I'm excited to see what the results are. I think it's going to be very interesting to finally hear what those results are. But most institutions really never adopted HIPEC because first of all, we didn't even have great data around HIPEC, and now, adding HIPEC on top of that when we don't have data on that either. Plus, it's very resource intensive and does increase the risk of complications after surgery. So most people were kind of waiting for some definitive data to really add HIPEC to their regimen, and it just never materialized. So I think very few places ever adopted it, and very few places are still doing it, if anybody. So
I was just curious.
Wow, great question. Great question. Yeah. So somebody's asking about whether EPIC is. I just answered that question. So those are the questions in the Q&A. There's a question here about somebody's husband who had appendix cancer, has had chemotherapy every 2 weeks for months, HIPEC and initial surgery. Oh, yes, in 2010 had an abscess drained on his appendix, but the appendix was not removed. When he was diagnosed with cancer, the physician said this could have been a link between his cancer and the fact that he had an infection on his appendix. Absolutely, yes. So definitely, I alluded to that data in my talk this year. We absolutely know that people with what we call complex appendicitis, so an appendicitis that presents with an abscess and gets drained, there is up to a 30% risk of a tumor being involved in that, whether it's coming from the appendix or not. It's not necessarily coming from the appendix, but it's most likely coming from the appendix. And I absolutely recommend 100% that people have their appendix removed at some point for complex appendicitis, not so much to prevent another episode of appendicitis per se, but to make sure that there isn't a cancer there. And we see this not infrequently, unfortunately. So, and many years out. Actually, I just recently took care of somebody who had her appendix removed 20 years earlier, and she actually had her appendix removed and it still came back. But so that just speaks to how slow growing this can be, that we can see actually have 3 people in my practice whose appendiceal cancer tumor became a problem 20 to 30 years later. So we do routinely, I think most surgical oncologists are not routinely following people after 10 years. We are following people out to 10 years, and we're not really sure what to do after that because the likelihood of it coming back is extremely low. But I always want people just to be on guard that it can come back at any point in time, and just to be aware of the symptoms and let people know if they're being seen for something, that they have the history of an appendix tumor. So, question, is there any time point after HIPEC when small bowel obstructions are no longer a risk? Well, I wish the answer was no. But I do think the further you get out without one, the less likely it is to happen. But unfortunately, and it's not just with site reduction in HIPEC, it's with any abdominal surgery. Adhesions can form, and obviously failing surgery for cancer, the cancer can come back. So you can end up with a small bowel obstruction. But the further you get out, the less likely it is to come. And, Erin, did you want to say anything, add anything more? Or?
No, I think the other thing to know is not all small bowel obstructions need to be treated with surgery. So sometimes we can manage people without it. So even if you're unlucky enough to get a small bowel obstruction, it doesn't mean we're going to whisk you off to surgery. And I think they're still not fun to manage, but we can often help people through it without surgery.
Yeah. And as a matter of fact, I mean, I think most, unless there's, again, an acute indication to go to the operating room, most surgeons and surgical oncologists will try to manage them without surgery. And oftentimes, it's successful. We can do that. So good, very good point. And then there's a question about Bromac. Oh boy, so as Bromac becomes available, so first, Bromac is going to have to go through the clinical trial, and it's, going to have to be tested to make sure that it's safe. And then to see if it works. And, I think hopefully, initially what we're going to see is that it's going to help with people who have, high volume mucinous ascites, the PMP, and to try to liquidate that so it can be drained more easily, because the really viscous, thick ascites is very challenging to remove with just a needle doing what we call a paracentesis. Ultimately, though, I think where we'd like to see it go is treating the more solid tumors. You saw some of those pictures of the more solid pseudomyxoma involving the omentum and, all those CT scans that people showed. If we can get it to break down that solid tumor to a liquid form, then we could remove that, or we either remove it through a needle with a paracentesis or remove it surgically and spare organs. So we're all kind of waiting desperately for this to become available here in the U.S. And I wish we could have heard the rest of Dr. Morris's talk. I don't think he knew that at the end of the book. I was kind of excited to hear where they've gotten with it in the trial down there and what future applications they're hoping to see. So I think that's what everybody's hoping. And Dr. Ryan did mention the folks in Spain have actually opened their own trial as well. So it is gaining traction around the world. I think people have a lot of interest in trying to do something directed towards the mucin to really help, because if we can prevent bowel obstruction or dysmotility from that encasement, then people can live with it. It doesn't spread to other parts of the body. So good question. And do tumors begin with a type of bacteria? Dr. Ward, thoughts on that?
I think the talks were amazing today, and they highlighted that there may be some connections there that I'm not aware of, but it sounds like I don't know of any specific tumor that causes, any specific bacteria that causes these tumors, but, based on all the amazing scientists that talked today, it sounds like there may be some connections between bacteria and tumors that I don't know, and I'm excited to learn more about next year.
Yeah, I also don't know of a direct cause and effect between bacteria and tumors, although what I think is fascinating is that if you, going back to the colon, if you look at the different genomic signatures of cancers in the colon on the right side versus the left side, they are very different. And if you look at the genome of the microbiome on the right side and the left side, they too are very different. And I think we're only at the tip of the iceberg in understanding the impact of the microbiology in that environment on cancer development and what type of cancer it is and how it's going to behave. And hopefully we can get some information on how to treat it as well. But I think,
And it's always interesting to think about the H. pylori phenomenon as well, right, which we know is associated with increased rates of cancer, and it's quite possible there's some bacteria causing inflammation of the appendix or something that we don't understand yet. Mm-hmm. I won't say never, or I think it's quite possible. I just don't know anything. Yeah.
I know the folks at the Mercy Medical Center, so Dr. Sardi and his group were looking at the role of H. pylori and appendiceal tumors and pseudomyxoma, and they even had a study looking at the role of antibiotic therapy to try to have an impact, and I don't think it's quite panned out where we hoped. I mean, it would be great if it hasn't panned out to the point where they're willing to say, you know, people should be on antibiotics in addition to other treatments. Just we haven't seen that there seems to be a relationship, but whether it's cause and effect, they haven't determined yet either. So more to come on that as well. So yeah. Judy, did you have another question?
No, I do not. That's it. I'm just looking at the questions. I think everyone has been answered in the Q&A.
Yeah, the last comment in the Q&A is just a wonderful comment and thanking the ACPMP for the symposium and the presentations today. So, yeah.
Well, it looks like we're right on the money. It's just about 4:30.
Yeah.
And to summarize, yes, the ACPMP Research Foundations thanks all the panelists for giving us your time today, which I know is quite a bit. Takes you away from your patients and your surgeries and your clinicals. But Dr. Lambert, one last question for you.
Okay. Where
could you possibly, thanks for the recommendation for Rings of Power, but where do you possibly have the time to even watch TV? I can't imagine where you even find the time for that.
Well, it's like the 1 hour that I spend with my husband on Friday night. We caught that, so it was good.
You are amazing. That's all I can say. Cannot praise you enough.
Well, thank you. I appreciate that. It's been
Dr. Ward. Thank you. I mean, I'm talking to Dr. Lambert quite a bit, but
that's great.
No, we appreciate your insight, and it is very important for all the patients and their caregivers to be able to understand, the depression that comes along with both, and everything that comes along with having this surgery, because it is a major surgery. And trying to explain it to your friends and family, that's another struggle, because you get the same question or the same question answer. Oh, it's your appendix. Just remove it. You should be fine.
Yeah, right, exactly.
If only.
If only, exactly.
If only.
Yeah, I always describe this as the perfect storm. It's a useless organ that that causes a rare cancer that nobody understands and requires like one of the biggest surgeries to deal with it. And it's just when you get that diagnosis, you really do feel like Alice in Wonderland in the rabbit hole. And where do you turn? And like I said before, the ACPMP Research Foundation is the place for people to turn to get the support, to realize they're not alone, get connected with experts in the field, understand that there are people working, doing research to try to find better treatments and cures for this, and just understand it better. So I think with that we'll probably end the session. And just again, Judy, thank you to you and all the folks at the ACPMP Research Foundation for all that you do to support everybody who's dealing with this disease.